Good afternoon, everybody. First of all, I would like to thank the organizing committee for giving me an opportunity to present the topic HIV and NAFLD in this meeting. This is the outline of my talk. I will start with the definition of NAFLD or non-alcoholic fatty liver disease and NAT or non-alcoholic steatohepatitis. I will walk you through the epidemiology of NAFLD or NAT in people living with HIV, which I will abbreviate as PWH for the remaining of my slides presentation, and diagnosis and staging of NAFLD and treatment of NAFLD. NAFLD is defined as the presence of excess fat in the liver, which means fat accumulates in greater than 5% of hepatocytes in individuals who do not have a history of significant alcohol use in the absence of competing other liver diseases etiologies, for example, chronic viral hepatitis or some medications that can cause fat accumulation in the liver. If fat accumulates in the liver without inflammation, it is called simple steatosis or NAFLD. When inflammatory cells infiltrate in the liver, this is called NAT or non-alcoholic steatohepatitis. Chronic persistent inflammation in the liver leads to fibrosis inflammation. If left untreated, this can progress to cirrhosis, followed by its complication of end-stage liver disease, for example, liver cancer or liver failure. NAFLD usually develops in patients with metabolic syndrome, which is a combination of obesity, diabetes, hyperlipidemia, and hypertension. And this leads to insulin resistance, which causes steatosis in the liver. Steatosis can induce the production of inflammatory cytokines and oxidative stress, resulting in hepatocyte necrosis and fibrosis, eventually cirrhosis. This is the pathogenesis of fatty liver in the general population who do not have HIV infection. However, pathogenesis of NAFLD in HIV-infected patients is more complex than in the general population. Besides the metabolic syndrome, there are some factors related to HIV itself and related to the treatment of HIV that contribute to NAFLD development. HIV has a direct cytopathic effect on hepatocyte, triggering apoptosis of liver cells. HIV can infect the tissue macrophages in the liver and stimulate the shift of macrophages to profibrotic phenotype, leading to fibrosis. It also promotes oxidative stress, resulting in hepatic inflammation. Those with HIV infection have impaired gut barrier, causing bacterial translocation. Lipopolysaccharide or LPS of the bacteria in the blood circulation can induce hepatic TNF-alpha and TLR4, which promote inflammation and fibrogenesis, also insulin resistant in the liver. Importantly, these changes are not fully reversed with the ART, resulting in persistent inflammation. Another mechanism of NAFLD in HIV is adipose tissue dysfunction. HIV patients have visceral adiposity and lipodystrophy, and this condition promotes insulin resistance. Some antiretroviral drug or ARV can cause fatty liver. This more commonly occurs when all ART regimens are used. For example, like PI can induce lipodystrophy, or NRTI, which can cause mitochondrial toxicity. Ritonavir-boosted PI can cause hepatocyte stress and more lipodystrophy and insulin resistance than other ART regimens. The new ARV regimen, for example, like integrase inhibitors, also they have safer metabolic profile, but they can cause more weight gain. For example, dolutegravir can cause more weight gain than raltegravir. This slide shows prevalence of fatty liver around the world. The prevalence of fatty liver around the world in the general population is about 25%, vary by geographic regions. For example, in Africa, it is about 13%, but in the US, it's about 25%. How about the prevalence of fatty liver in HIV-infected patients? There was the first systematic review and meta-analysis examining the prevalence of and risk factor of fatty liver in HIV mono-infected patients. This was published a couple of years ago, and it was shown that the prevalence of fatty liver in people living with HIV is much higher than the general population. That is 35% of patients have NAFLD, 42% have NAT, and 22% have hepatic fibrosis. Factors associated with fatty liver in HIV-infected patients include the other risk factors that we found in non-HIV-infected patients, for example, like the metabolic syndrome. Interestingly, the high CD4 cell count is also associated with fatty liver in HIV patients. By contrast, the HIV itself, the viral load, the duration of HIV infection or the duration of treatment were not associated with fatty liver in HIV patients. NAFLD has become an important health problem around the world because this is one of the leading causes of death and also causes of cirrhosis and liver cancer. This study was done in the US. It showed that fatty liver is the second leading etiology among patients who are waiting for liver transplantation in the US. Among those with HIV infection, the liver disease is also one of the most common causes of death after the first year of diagnosis of HIV. Moving on to the diagnosis and staging of fatty liver. Liver biopsy is the gold standard for diagnosis of fatty liver. This can distinguish between steatosis, a simple steatosis from NAT, and it can also identify secondary causes of liver disease and stage fibrosis. However, there are some limitations of liver biopsy for the diagnosis of fatty liver. This is invasive methods. It has some risk of complication. It is also expensive. And importantly, the accuracy of liver biopsy for accessing steatosis has also been questioned because of sampling errors, intra and inter-observer variability, also the inadequate specimen size, and this may lead to overstaging or understaging of steatosis. Because of these limitations, non-invasive tests have been increasingly used for diagnosis of fatty liver. There are a couple of radiology imaging that can be used to diagnosis of hepatic steatosis of fatty liver: ultrasound, CT, MRI, or control attenuation parameter or CAP. The trade name is FibroScan. Among these, ultrasound is the preferred first-line diagnostic procedure for fatty liver. This slide shows the image of fatty liver. This is liver and this is kidney from the ultrasound. In normal liver, the echogenicity of the liver is very similar to the renal cortex. When fatty liver occurs, the liver has increased heteroechogenicity compared to the renal cortex. So the renal cortex seems to be darker and the hepatic parenchyma seems to be brighter. And this is my fatty liver. And this is moderate fatty liver, and this is severe fatty liver. So in severe fatty liver, it is very difficult to see other structures, for example, like the vessel or even diaphragm by ultrasound. This slide shows the methods that we can use to measure the fat. This is called controlled attenuated parameter or CAP of FibroScan. This is very easy to perform, and very short duration, for example, like just only 3 to 5 minutes to perform the fibroscan. The advantage of the fibroscan is that it can give you the number of fat, and also it can measure the it can measure the fibrosis in the liver as well. The control attenuated parameter or CAF at the cutoff of 238 give the AUROC of 88 with high sensitivity and high specificity. There are many tools, but ultrasound remain the preferred method because of its availability. You have ultrasound in every hospital, but some hospitals do not have fibroscan. Once fibrocystinosis is diagnosed, the next step is to determine whether the patients also have liver fibrosis or not. The liver fibrosis is very important because the amount of fibrosis is the main determinant of prognosis in patients with NAT. If you have a lot of fibrosis, you have shorter survival than those without fibrosis. There are many methods that can be used to diagnose hepatic fibrosis. The ultrasound can also be used to estimate the fibrosis measured by elasticity. It is called shear wave elastography. The newer version of the ultrasound have the software program that can do the shear wave elastography. So when you do the ultrasound, you can diagnose the fatty liver, and also you can measure the stiffness of the liver. If the stiffness is increased, it means that you have fibrosis. Another method is MR elastography or fibroscan, as mentioned earlier, that you can measure elasticity of the liver as well. Other non-invasive methods is serum-based assay. This is our commercial assay, which is very expensive and not available in most hospitals. So the easier way to do is to do the calculation of the predictive clinical models for advanced fibrosis. These are 3 predictive models that can easily use in practice. The first one is called NAFLD fibrosis score or NFS score. The second one is FIB-4 score or fibrosis-4 score. And the third one is APRI index or AST to platelet ratio index. You can see that the parameter to plug in the models is just a simple lab that you can test in every hospital. For example, like AST, ALT, platelet, and albumin. Each score had its own cutoff to determine significant fibrosis. The performance of this is quite similar. You can use any one. And also there are another cutoff to exclude the significant fibrosis, which high negative predictive value. For the treatment of HIV, NAFLD, in the general population, the mainstay of the treatment of NAFLD is lifestyle intervention, reduce the calorie intake and weight reduction. If the patients can lose weight greater than 5%, there is improvement in histology. The stenosis will decrease. If the patient can lose weight about 7 to 10%, NASH will improve. And if the patient can lose weight greater than 10%, fibrosis can improve. And this study has been done in the general population in non-HIV infected patients. There is no trial in the patients with HIV. This intervention has not been tested in patients with HIV, but we think that the lifestyle intervention with weight reduction can also help in fatty liver in HIV patients. What about pharmacotherapy? The vitamin E is the first-line therapy for NASH in HIV-negative patients. And this is the first single-center phase 4 open-label single-arm study just published a couple months ago, studied the effect of vitamin E in HIV mono-infected patients. There were 27 HIV-infected patients receiving vitamin E 800 international unit daily for 24 weeks. At the end of treatment at 24 weeks, the ALT decreased and CAP decreased. When follow-up, the proportions of patients with normal ALT increased over time. Similarly, the distribution of hepatic steatosis, the patients without hepatic steatosis or reversion of steatosis increased over time after receiving vitamin E. It is important to note that vitamin E can improve steatosis, improve inflammation, but there was no improvement in liver fibrosis. This might be due to the short duration of the treatment, just only 6 months. Another treatment specifically for treatment of fatty liver in patients with HIV is a drug called tesamorelin. This is a growth hormone releasing analog, which is FDA approved for the treatment of HIV associated with lipodystrophy. This is a randomized multi-center trial in 61 HIV patients with NAFLD and received the drug for 12 months. But interestingly, the steatosis was decreased by about 1/3 in the treatment group and increased by 5% in the placebo group. And the proportion of the patients in the treatment group has more proportion of patients with reversal of steatosis, 35% as compared to 4%. In the treatment group has less proportion of patients with the progression of liver fibrosis, 10% as compared to 37%. Another thing that we can do to treat fatty liver in HIV patients is the careful selection of the ARV regimen. The older regimen of the ARV can cause fatty liver. However, the new ARV may lead to fatty liver regression. This is a study published in 2017. It is a randomized study. Enrolled about 40 patients with HIV with fatty liver who were on efavirenz plus tenofovir and emtricitabine and randomized into 2 groups. One group, the control group, continued efavirenz, and the second group switched efavirenz to raltegravir. After 48 weeks of the treatment, the raltegravir group, we can see that the steatosis decreased while the efavirenz group has increase of steatosis. In summary, in patients with HIV infection, if they have any of the following conditions, we should suspicious of the fatty liver. Those who have metabolic syndrome, lipodystrophy, or persistent elevation of the ALT. After we exclude other causes of elevation of ALT, for example, alcohol use, viral hepatitis, autoimmune hepatitis, or drug-induced liver injury, we should think about the fatty liver as a cause of elevation of the ALT. If we suspect the fatty liver, the first investigation tool is ultrasound. If you have the fibroscan, you can do the fibroscan to measure the CAP as well. After fatty liver is diagnosed, the next step is to stratify the risk of fibrosis, and you can use a clinical prediction score. The easiest one to do is a FIFO score, and this can be done using the online calculator. We can divide patients into 3 groups: high risk, intermediate, and low risk group, based on the score of the FIFO. If FIFO is less than 1.3, it means that the patients have very low risk to have the fibrosis in the liver. In this group, you can recommend lifestyle intervention. reduce the weight, exercise, and repeat the assessment of the fibrosis in the next year. If the patients have the FIB-4 score greater than 1.3, it means that the patients have intermediate or high risk to have the fibrosis. I would recommend that you refer to hepatologist to careful investigation and have the treatment for the patients. In summary, NAFLD or NAT is one of the most frequent liver diseases in HIV mono-infected patients. In these patients, NAT can progress to cirrhosis and its complication, and is one of the cause of death in these patients. The diagnosis of fatty liver is made by non-invasive tests. Once the fatty liver is diagnosed, clinical predictors can be used to stage of the fibrosis. And fibrosis is a predictor of survival and prognosis of the patient. So this is very important. Lifestyle modifications is the mainstay of the treatment. Pharmacotherapy, for example, like vitamin E, is recommended in more severe cases. Thank you for your attention.